Hello, it's Jeremy Woodward here. I'm a consultant gastroenterologist in Cambridge, and I've been asked to speak about potential celiac disease, which is a significant issue for us and one which many of us are troubled with on a regular basis. I must just say a big thank you to all of the staff at Coeliac UK and the organisers of this meeting for keeping the show on the road in these interesting times. So we'll start off by just looking at the definition, and no better place to start than our current definition, as from the Oslo group in 2013, published in Gut. And really, our understanding of potential celiac disease, previously called latent celiac disease, is that these are people who have normal biopsies of the intestine, but are at risk of developing celiac disease as indicated by positive serology. That leaves quite a lot of options open, and there's a lot that we need to explore around that. So our main diagnostic tests in celiac disease are serology, the anti-tissue transglutaminase antibody, or the endomysial antibody, and the confirmation with biopsy showing villus atrophy. And it would be really nice if these always lined up in this way and gave us a very clear diagnosis. When this does occur, it's very useful, and we can be fairly certain about the diagnosis itself. Unfortunately, the situation is a bit more like this, with a skew, and we find that the proportion that we can be certain about with the biopsies and the serology lining up is not 100%. We see people who are seronegative with villus atrophy on biopsies, and we see people who have normal biopsies but positive antibodies, here in blue, the potential cases. These are the numbers and the proportions that we had in Cambridge over the last year, and as you can see, about 16% were potential. This ties in very nicely with publications from other centres, mostly in Italy, saying around 20% of cases come into this potential bracket. So not an uncommon problem that we have to deal with. There are a couple of obvious possibilities as to why this might be the case. No test is absolutely perfect, so we will inevitably see false positive blood tests and false negative biopsies in this setting. Looking at the serology, first of all, the problem here is that we don't have a standardized test. So these are the numbers of different kits available when I last looked, which was around 2015 for the latest NICE guidance. These are the IgA TTG antibody test kits available. There are 27 of them here, and they will all perform differently in terms of their numerical ranges and also their dynamic ranges in terms of the multiples of upper limits of normal. Therefore, when we're talking about potential celiac disease in our groups of patients, and if we're publishing on it from different centres, it's quite likely that we're actually going to be talking about different things because our tests will all perform somewhat differently. This makes it difficult to translate publications from different centres as a result. This was the table that was used for the sensitivity and specificity of the serology tests in the latest NICE guidance. And again, the studies are all prone to bias. I think the best study is the one from Sheffield, where there was least bias in the selection of patients for serology and biopsies. And as you can see, for the TTG assay, there was a sensitivity and a specificity each of 91%. What this means is shown here. So if we consider the biopsy to be the gold standard, if we have 100 patients who have celiac disease and 100 patients who don't have celiac disease, these are the proportions and the colors in the same way that I've just shown you on that Venn diagram at the beginning, with about 9 out of the 100 cases in each case being a false test. However, we know that real life isn't like this, in that many more people are not celiac than celiac. And in fact, in the general population, it's only about 1%. So if we scale up the right-hand column, it looks more like this. And in this setting, we can see large numbers of potential celiac cases because the specificity of the test is only around 91%. Where we have a low existing prevalence in the population, the the specificity really is much more important than the sensitivity in this setting. And it's the specificity of the test that will vary the proportion of potential celiac cases that we get. So now let's look at the other possibility, which is of that of a false negative biopsy. We've always held this up as being the gold standard, but worryingly, things are looking as though this isn't always the case. First thing is that many of our patients will already be following a gluten-free diet. We may not know about it, and there's plenty of reasons why people are doing this for perceived health benefits, not just because they think they have celiac disease or symptoms. Equally, those patients, when we do identify that they're restricting gluten and we ask them to do a gluten challenge, we don't really have any handle on how well they're doing a gluten challenge or how long for. They may curtail it themselves if they have symptoms, but also worryingly, in the small number of publications looking at controlled trials of actually giving gluten challenges to people and assessing their responses, for instance, the study carried out by Dan Leffler in 2013, we found that a relatively high proportion of people remained at MARSH 0 or 1 after 2 weeks of gluten challenge. In that case, I think it was 6 out of the 19 patients actually showed either normal changes, normal biopsies, which is MARSH 0, or increased intraepithelial lymphocytes only, which is MARSH 1. The other problem is the interpretation of the biopsies, and this was a real eye-opener to me, I have to say. This was a landmark study from Finland. The biopsies at the top, A and C, were reported as showing minor changes or normal. Those at the bottom as showing moderate to severe villus atrophy. The problem is that A and B come from the same patient, in fact the same biopsies, just sectioned differently, as do C and D. So interpretation, the cross-sectioning of sections, the orientation of the biopsies is critical in our interpretation of biopsies and is not always going to be the gold standard we think it is. Finally, another landmark study from Finland showed that even people who have subvillus atrophy grades of celiac disease with mild enteropathy show significant symptomatic improvements on many occasions with being on a gluten-free diet, here shown for each group, with the dots on the left being before and those on the right being after initiation of a gluten-free diet for these two symptomatic scores. There are, of course, other possibilities for this setting of potential celiac disease. First is that it might be an early warning. Now, once again, the literature is varied on this. When we look at this study from Finland, those who were antibody positive and had minimal changes in the biopsies, the majority went on to develop villus atrophy after 7 years. But in a recently published study in children, the Celiprev cohort, only 13% went on to develop villus atrophy after 10 years. So a lot of variability in understanding whether this really demonstrates an early warning, and this may again relate to the way in which the assays of the antibody tests perform in different centers, and perhaps also different age groups. So this opens up another possibility, which is that actually these people with potential celiac disease represent a sort of form frust, a partial expression of celiac disease. That's not inconceivable, given that we know that there are a large number of immunomodulatory genes implicated in the pathogenesis of celiac disease, and the varied expression of those different genes might affect the expression of the disease. And interestingly, this study from the Paris group back in 2007 followed up patients who had been diagnosed in childhood but lapsed on the diet, of whom 13, surprisingly, then had normal biopsies many years out. And this led some to consider the possibility, here I've just drawn it in a diagrammatic fashion, that we could have both biopsy changes and also serology markers hovering in this sort of low level around the diagnostic threshold. And we've certainly seen people where they don't add up, they don't match. So in some cases, annoyingly, we might have a positive low-level TTG antibody with normal biopsies. And then when we rebiopsy, surprisingly, we find sometimes the biopsy does now show villus atrophy, but the serology is negative. So they seem to hover independently around this line sometimes. So we looked at our cohort in Cambridge, and having identified a group of patients from all the positive TTG antibody tests and looked at their biopsies. This was over a period from 2003 to 2008, and recently just reviewed their records on an observational basis back in at the beginning of this year. As you can see, the percentage potential is exactly the same as we saw in our 2019 cohort, which is encouraging. Of these, we included those with MARSH1 changes, just increased intraepithelial lymphocytes, as well as those who had normal biopsies. And for clinical reasons, which could include symptoms and symptomatic response to gluten exclusion, strong family history, for instance, or other autoimmunity, we treated the majority of those who had MARSH1 changes as being celiac, and they were started on a gluten-free diet, whereas a minority of those who had normal biopsies were treated as being celiac. Over time, and 3 years later, we had one further patient who developed villus atrophy in the MARSH1 group, and around 20% in the MARSH0, the normal biopsies group, at a range of around 3 to 4 years on average, but as long as 13 years ago, after the initial biopsy in one case. If you look at the right-hand side, there were 2 patients in the MARSH0 group who over an 8-year follow-up period had persisting normal biopsies. And looking at the type 1 diabetic group separately, 4 of the 7, all of whom were MARSH0, and these were all picked up on serology testing routinely in the diabetic clinic, over this period of time developed villus atrophy. There are 2 instances that I want to particularly highlight here. Firstly, is that of that group of those with normal biopsies, over an average of 10-year follow-up and up to 16 years follow-up, 34 of them have had no further investigations and no further suspicions of having celiac disease. My concern here is that having had a negative biopsy, their clinicians and they themselves may feel that this has excluded the possibility of celiac disease henceforth, and they therefore may include many people who have gone on to develop celiac disease, but the threshold of the diagnosis has been raised by having had a negative biopsy. And I think it's very important that in this group, we are very careful with the communication around this and the follow-up, which clearly needs to be longer term. The other group that worry me is over here on the left. There were 2 patients in the MARSH1 group who were treated as celiac, who later went on to develop villus atrophy, suggesting that their adherence to the diet was poor. I think this is probably the main take-home message about any clinicians treating potential celiac disease. Because if you think about it, any patient following a gluten-free diet, it's actually extremely challenging from their own personal perspective, socially restricting, and they need a lot of support to be able to follow this diet, certainly initially. Thankfully provided by ourselves and also organizations like Coeliac UK. But if as a clinician, you're telling that patient right at the beginning that there's significant doubt about whether they have the diagnosis or not, then their ability to be able to maintain that diet is going to be very poor. They're going to fall at the first hurdle effectively, and as soon as there's any possibility that they might be able to make up in their own minds that they don't have celiac disease, they will be eating gluten again. And so I think the main message here has to be that we have to come up with a clear diagnosis for them. They have to choose whether they are gluten-free or not, because partial gluten-free diets or doubt in their diagnosis is not going to help them in the long term if that's the path they choose to be. So in our practice with our MARSH1 positive TTG patients, we always do a check HLA to make sure it's compatible, but if they are, we recommend treating them as celiac on the basis of our experiences and making a firm diagnosis. This can obviously be on a case-to-case basis, and it may be that individuals may choose otherwise and follow the pathway that I've described below, which is for those with entirely normal biopsies and entirely normal biopsies that have been reviewed with the pathologist and have a positive TTG and also compatible HLA. We usually carry out a repeat biopsy if the patient is willing and try to encourage them to max out on the gluten. There is a large amount of patient choice with this because clearly there will be false positive TTG results coming through. And if patients are entirely asymptomatic or have no benefit on being a gluten-free diet, they might wish to continue eating gluten. In those cases, we think it probably doesn't do too much harm over a 2 or 3 year period if they do convert to villus atrophy, and we can then detect that if we're surveying them with 2 yearly biopsies. I don't know how long we should have to continue that for. Or they can choose to be treated as celiac, but no halfway measures. This has to be absolutely black or white. A gluten-free diet is a gluten-free diet, and if they decide to be treated as celiac disease, then that is their choice from then on, and it's a lifelong absolute gluten-free diet. However, it would be really useful if we had a different test that we could apply here in this patient group to work out whether they truly had celiac disease or not. So a Dutch publication recently has looked at the proportion of gamma delta T-cell receptor bearing intraepithelial lymphocytes on flow cytometry in patients with celiac disease, and shown a cutoff value of 14% resulted in a 66% sensitivity and a very high specificity for the diagnosis of celiac disease. Interestingly, this fabulous paper from Banajabri's group in Chicago showed that the changes in the intraepithelial lymphocyte population, such as the increase in gamma delta proportion and the types of gamma deltas, is actually permanent after people have developed celiac disease. So we've tried to replicate this Dutch data ourselves by looking on flow cytometry at different populations of intraepithelial lymphocytes. This is our data for the gamma delta proportion, and we've separated our patients into 6 groups. Those on the bottom left are those with villus atrophy and positive tissue transglutaminase antibodies, so ongoing active celiac disease. We've got a variety of different non-celiac enteropathies represented. The controls are patients who are having duodenal biopsies for other reasons and have entirely normal biopsies with negative tissue transglutaminase antibodies. We've got a group who are long-term celiac patients on follow-up on gluten-free diet, all with normal biopsies on gluten-free diet for periods of up to 12 or 15 years. And we've got this group of potential at the end there. And you can see that the cutoff value of 14% there, as applied by the Dutch group, is not enormously useful in our populations to separate out these different groups. This, interestingly, gives us a very similar sensitivity of around 63%, but a lower specificity of 92% compared to the Dutch group, and as a diagnostic test in its own right is not of great utility. However, if we look at a different aspect of the cellular population, the proportion of cells that express both surface and cytoplasmic CD3, the T-cell marker, as well as the gamma deltas here shown on the y-axis, we get something quite interesting in our population. This, every single dot here represents the CD3s and gamma deltas plotted for an individual patient, or in fact an individual biopsy, as I've repeated some to be certain as to their reproducibility. This looks a bit like a random jumble of dots until you separate out the different groups. And here are those who have active celiac disease, villus atrophy, and positive serology. And you can see the majority of these are above this line that I've drawn in here, which equates to, rather conveniently, if you add up the percentage of CD3s and double the percentage of gamma deltas, if that comes to 100 or more, then these patients are likely to be in the celiac group here over on the top right. Compare this to the controls, and you can see that most of them lie below this line. But interestingly, we then have to look at those individuals who fall into different groups. And here we've got one patient who was really very strictly restricting gluten prior to the biopsy and probably underwent an inadequate gluten challenge. And so I wonder whether that patient who is subsequently labeled as being non-celiac actually did indeed have celiac disease. And if we look at this, this is the red line is our cutoff here. You can see this that now gives a very useful diagnostic score with a sensitivity and specificity in really good ranges now for using this as an applicable tool in diagnosis. Interestingly, when you look at the long-term follow-ups, a few are below the line, most are above. This fits in with the work from Chicago showing that the IEL populations remain altered throughout life. When we look at those below the line, first of all, it actually enabled us to revisit some of these diagnoses, which were made on really dubious grounds. This was a patient who was diagnosed purely on the basis of a positive anti-gliadin antibody, but was TTG negative and didn't undergo biopsy. This is a patient diagnosed in 1950 before there was any useful diagnostic tools available. This patient was diagnosed only on the basis of a positive DQ2 or a compatible DQ2, which isn't a good way of diagnosing celiac disease, and another one diagnosed over 50 years ago. Both of those diagnosed in ancient times, we subjected to a 3-month challenge and they remained asymptomatic and biopsies remained normal, as did serology, so they almost certainly don't have celiac disease. But looking at those above the line, this shows that these patients who have normal histology, but an abnormal IEL population can be detected as and diagnosed as celiacs, even though they have normal histology and are following a gluten-free diet. So this test enables us, I think probably the only test that enables us to diagnose celiacs with normal biopsies on a gluten-free diet in this setting. When we look at the potentials, there's a bit of a mishmash, as we might expect, and this would fit with some false positive blood tests and perhaps false negative biopsies in some instances. If we look at those above the line, I've coloured in those in red here that subsequently develop villus atrophy on follow-up. So it's identified those by this test, and those in purple are those with symptoms. Those below, there's one who's non-compatible HLA, and others generally MARSH 0 and quite possibly genuinely don't have celiac disease. This is work in progress and we'll have to see what happens over time with these patients and whether they develop celiac disease. You can see there's one right up at the far left who has had 5 biopsies, all of which have been entirely normal despite low-level tissue transglutaminase antibodies. And again, I don't know how long we should be following such patients up for to see whether they convert and whether the flow cytometry results like this give us a useful indicator that they're not going to develop celiac disease or not. Only time will tell, and we'll need to evaluate this test in this setting a little bit better. So in summary, I think it's really important to know how your TTG assay performs. That'll dictate the size of this blue area of the potentials in your own population, and everybody will be different, and we can't necessarily translate the results from different publications or different centres into your own area. I'm completely at sea if I see a patient who's had a TTG assay done in a different laboratory. It seems to mean something completely different. I think some potential celiacs are genuinely false positive blood tests. I think they have to be due to the nature of the test itself. And I think some potential celiacs are gluten restricting and therefore have false negative biopsies effectively. And that's why we encourage rebiopsy and make sure that they are having a good gluten load. I think those with subvillus atrophy but not normal biopsies really are celiac. Unless there are good grounds, we probably should treat them as celiac. And I think whether this group of potentials might represent an early warning of further development, or perhaps this form first of low-level immunological activity requires long-term follow-up and further study, and maybe really biologically very interesting, particularly in the latter instance. And it would be useful to do further genetic studies on these cases. I can't stress enough the importance of a definitive diagnosis and clear messages to the patients in terms of following a gluten-free diet. Once that decision has been made to be either celiac or not, it has to be stuck to, and that has to be a black and white decision with no doubt remaining for the patient. If there's any doubt, then I think you can guarantee that they're likely to waver from the diet, and we won't have done them any favors at all. And flow cytometry may provide a useful tool in the future, and we're evaluating this and looking to see whether it may help us in some of these situations, but also to help us understand whether we can identify those patients in the above groups. So finally, I think that we probably need to start thinking about a redefinition of celiac disease in many ways based on all of this. And perhaps it's time for Oslo too. I'm wondering if Jonas might consider, perhaps after COVID has blown over, we might do this rather than by telephone, but as a face-to-face to get together again all together. Perhaps in Oslo, perhaps Oslo too. I'll wait and see if he picks up the hint. Thank you for listening.